we are coming to dementia, and it's a big chapter, and we will take a good amount of time in this. Basically, as you know what dementia is, basically dementia is a disease where the patient can form new memory, or in some cases they lose their old memory, or both in different percentage. So that's the dementia. And in UK, since the geriatric population, which is usually healthy from the organic level, dementia is one of the most notable disease which is affecting them very much, basically. And most of the geriatric population, geriatric disease, dementia actually tops the list. In all of this, very common one is the Alzheimer's disease. In UK, if you look at, very common one is the Alzheimer's disease. So, and the next one is the vascular dementia, if you look at the UK statistics. And the third one is the Lewy body dementia. So that's the statistics, if you see, so that what are exactly happening. Now, how to diagnose dementia? Now again, you are not expected to diagnose dementia, but certain scales and certain values you need to memorize during your examination. So we are coming to that. So diagnosis of dementia. Remember, there are certain things. It can be diagnosed in the non-specialist center, where and you are expected to be knowing these scales. So these scales are either 10-point cognitive screener, values you need not remember, or 6-item cognitive impairment test. Cognitive impairment test. Values are not needed. You do not have to diagnose from this. Just remember this because they can ask you where they are used. In specialist center, use mini mental score or mini mental state examination. Mini mental state, there they actually check. Full marks is 30, less than for 24 means it is dementia. It is suggestive of dementia. This one is usually asked. This one you need to remember. What else? We can also go for abbreviated mental state score. And all of a sudden, and sometimes we can also use GPCOG, which is General Practitioner Assessment of Cognition. These are the scores. Scores you need not memorize. Only mini mental score, you need some idea about that. And then you have to know which are used where. That's the whole thing. Now, how to approach a case of dementia? So again, in exam, you can be given a condition. From the question, you have to find out how much is known so far and how much is to be derived. So accordingly, whether it is the first time the patient is meeting you, or it is in between the therapy is meeting you, or it is at the end they are meeting you. That way, it's the dynamics of the disease they will be testing. So, approach to a case of dementia or suspected dementia. First of all, what are the things that you have to check? Definitely CBC, complete blood count or full blood count you have to do. Urea electrolytes, LFT, calcium, glucose. These are the things. Thyroid function test, vitamin B12, and folate level. Usually remember, blood folate level is not very satisfactory. Red cell folate level is a little more satisfactory, so they can go for that. If nothing is written, folate is sufficient. Now, and one more thing, this folate level is very much fluctuating. If you take some food containing folate, a large meal containing folate, your folate level may spuriously go high or may spuriously mask the condition. So red cell folate is a better indicator than normal blood folate, and that's why we do not generally prefer to do blood folate in day-to-day practice. So these are certain things. Second, once these things are done, in the next level you have to do an imaging. Why we need to do the imaging and what type of imaging? Usually CT scan is okay, and by imaging we try to look out for subdural hematoma and normal pressure hydrocephalus. These are very, very important points, which points to the subdural hematoma, that is the lucid interval. So this is actually the bleeding from the bridging vein, and the patient might have some injury. Occasionally, the patient may not have any injury. They are just elderly, frail, and there is high chance of acceleration, deceleration injury just because the brain is decayed and the skull is a little bit over voluminous. So there's some empty space, so brain can move, accelerate, and decelerate within the skull, making them more prone to development of trauma. Occasionally, also, so there is some history of trauma, and it is also very common if there is a history of alcoholism. So these are the points which may point towards subdural hematoma, and then characteristic CT scan finding. Regarding normal pressure hydrocephalus, that's something, urinary incontinence is there, dementia is there, and the balance that problem is there, the patient's personality change is there. So that's something. So if you find a condition where the patient is having dementia, patient is having some kind of balance problem, and patients in also discussing about urinary problem in an elderly, so also think of normal pressure hydrocephalus. So in such case, they will also mention the ventricle size and the pressure inside. If they are doing any lumbar puncture, they will also mention about the pressure of that. So these are certain areas which you need to know, and these are the approach. Once these things are done and dementia is confirmed, then we have to look for the etiological diagnosis or etiological approach to dementia. So what are the causes? Most common causes I have mentioned, that is Alzheimer's. After that, we have multi-infarct dementia and Lewy body dementia. Certain rare cause of dementia is prion disease, Huntington's disease, Pick's disease. I'll discuss about Pick's disease in a short while. So basically, Pick's disease patient, they have multiple lobar atrophy in brain. I will come to that. That can be sometimes viral disease, and most commonly this is HIV. So if the patient has already developed terminal AIDS, 50% of AIDS patient will give you history of some kind of dementia. Remember, whenever we are getting a case of dementia, we need to identify that geriatric dementias are usually irreversible. So we can't help. But first of all, yeah. So whenever we are discussing about dementia, we need to identify whether there is any reversible cause of dementia. First, we need to identify that. So what are the reversible cause of dementia? Check for the thyroid status. If the patient is having hypothyroidism, that's a reversible cause of dementia. Whether the patient is having Addison's disease, that's a reversible cause of dementia. So check for the condition, basically. Then B12 deficiency, folate deficiency, these are, and thiamine deficiency. These are, so B vitamin deficiency, these are reversible cause. Then what? If there is a tumor in the brain, so any SOL, if there is an infection in the brain, so these are reversible cause of dementia. Subdural hematoma, definitely it's a reversible cause of dementia. Depression, yes, treating depression. Depression is one of the very common cause of dementia. So treating that can help the patient. Whether the patient is on any substance, look for that. If the patient is on a substance abuse, check for that, and that can be dementia. Normal pressure hydrocephalus, to some extent, that is also treatable, and you know, in case, as I have mentioned, another very common, not very common, but important area is syphilis. So neurosyphilis, that can also cause dementia. So we can treat that to some extent. So these are the factors, first of all, we need to identify. Once these things are identified, now we have to, suppose we are not getting any reversible cause, then we have to check for the irreversible cause.